Welcome, everyone. I'm David Rakoff, Director for the Stanford Center for Population Health Sciences. So glad that you could join today, and this hour is really going to be worth your time, I promise. We're really lucky to have Dr. Eddy here today from Bradford, UK. She works as a postdoctoral fellow at the Center for Applied Education Research. She recently got her PhD in developmental psychology from Leeds, and has for the past 8 years been working with Connected Bradford data, which you'll soon hear a bit about. But from my perspective, it's really kind of the gold standard, our North Star, and the kind of things we want to be doing. Starting with data, moving to research, and thinking about impact, and having that impact and working with communities and governments as central to the reasons for having data and the research that you're doing. So it's just fantastic work that she's been a part of for the last 8 years. And we feel so fortunate to have you here today and looking forward to your talk. Thank you.
Great, thank you. I will caveat this by saying I can't take credit for all of this, but I will do my best to summarise all the great work that's been happening in Bradford and then move more specifically onto the stuff I've been working on. So to give a little bit of context for people that don't know, Bradford is quite a unique city in the UK. We've got a really young population, so it makes it great for understanding childhood development. It's really ethnically diverse. We've got a high proportion of ethnic minorities in Bradford, so we've got about 32% more Asians than the UK average. We've also got a quarter of the population in poverty. On contrast to that, we've also got some of the most wealthy wards outside of London as well, so we really get great opportunities to look at socioeconomic differences. And as well, it's one of the largest urban districts in England, so again, lots of people study. And finally, unfortunately, in Bradford, we have a lot of poor physical and mental health. So I think the diabetes rate is about 4% higher than the national average, but also education as well. It's about 10% lower the amount of children that leave mandatory education with their GCSEs. So unfortunately, not a great situation in Bradford, but it makes it a really interesting place to do research. So Born in Bradford itself was set up to start understanding, I guess, all these differences. It started out life as a longitudinal birth cohort, and we recruited around 13,500 children that were born in Bradford between 2007 and 2000. We've got about 176 sets of twins, and each set of twins has a photo shoot every year. These are from sort of 2007 onwards, all the way up to last year, when in COVID they are now wearing masks. So the sort of bib data that we collect, when a mother was recruited at her prenatal assessments, they took a baseline questionnaire looking at sort of lifestyle, alcohol, drinking, drug use, but also socioeconomic status, ethnicity, etc. We then use routinely collected data, so education records, healthcare records, but what we do on top of that is add in research data as well. So these children have been followed up in a number of sweeps now, through primary school largely, so sort of aged 4 to 5 years, and then 8 to 10 years, looking at sort of more cognitive measures like working memory, attention, things like motor skill as well. And what's really exciting is now we're moving into a new phase of data collection. These children are just about to enter secondary school. So we're now following their lives through that. And I guess Born in Bradford itself has evolved beyond just the longitudinal cohort data. It's now much more than that. So we have something called Bib for All. So that is a new sort of cohort that's been set up. It's continually open. That isn't going to have any sort of research testing on it, but that's going to allow us to track their health through administrative data across time. We've also got Born in Bradford's Better Start, which was funded by the National Lottery to look at a specific area in Bradford and do interventions on early childhood, so things around breastfeeding, obesity, in really challenging districts in Bradford. We've got Age of Wonder, which is our secondary school sweep of data collection, where they're doing lots of co-production with teenagers around their priorities, what they want us to be looking at, and largely it's coming out around mental health, physical health, and digital divide, so that sort of stuff. We've then got Born and Bred In, which is where Born and Bradford are trying to share their expertise and help set up Bib for All in different sort of areas of the UK as well. So there's becoming a greater sort of understanding across the UK. And then we've got Connected Bradford, which is probably one of the newest, I guess, bits of it, and I'll go into that a little bit more now. So Connected Bradford is the UK's first connected data set, which includes sort of education, health, social care, crime, and emergency service records for all children and all people within the Bradford district. So I think we've got about 600,000 linked records from the last 40 years. And what I will say is this isn't fully ready yet. We're using it in sort of bits and bobs to try and make sure that these linkages are working. And they've started out with the sort of autism pathway, and it looks like it's doing what we're wanting it to do. But just as a caveat, that data will be available to you guys. They're very keen on the Stanford Bib collaboration. It's just it might take a little bit of time for that to be sort of ready. So why, I guess, Connected Bradford came around? Well, we know that there's currently services that are working in very separate silos. They all have their user groups that are sort of generating their own sets of data that they're then using to analyse their own services and what they can do to improve those. But like I say, they're working very separately at the minute. But in reality, what we see is that the same users do access multiple of these services. So what would be more useful is if we're able to track these users through these services and also across time, so we can better understand their needs and what's happening in their lives. So just to caveat this, we know that this data is quite powerful, we're really excited about it, but it's not good enough on its own. We know we need the backing of sort of politicians and local government to be able to do it. We had our big event in July last year to sort of bring together policymakers, academics, schools, the education system, the health system, to try and get everyone on the same page to sort of really put a mandate forward for this. And it went really well, which is good. We know there's got to be appropriate ethics involved so that that happens. But also we know, particularly in Bradford, given the demographics, all of this needs to be co-produced. We need to make sure that voices are heard. And we do that through communicating not only academically through papers, but also in local communities. So the example on the screen there is in Holmwood, probably the most deprived area of Bradford. They hold sort of community dinners where they will disseminate what's happened since they set their priorities and how they're moving that forward. And all of this work is sort of situated within Born and Bradford, but also within the Centre for Applied Education Research, which was set up alongside Born and Bradford to really start looking at the intersection between health and education and really start understanding some of those barriers that lie beyond the school gates. So, for example, we were having a lot of issues with vision in Bradford. Not a lot of their parents were taking children to their routine vision screening. Unfortunately, they weren't aware that they would get free glasses and free screening, so parents weren't turning up. So what we've done is moved that service into schools. So they get their free screening in schools, everyone's there, they'll get it. They also get 2 pairs of glasses now, so one that's constantly left at school so that they'll always have one at school, and one that they can take home. So that's just a bit of an example, but we work across sort of 8 different themes, and it's a large collaboration between regional universities, Born and Bradford, but also the Department for Education and the Education Endowment Foundation and the NHS Trust as well. So to give you an overview of some of the things we've learned so far, so this is some of the highlights from, I guess, the BIB group recently. So we know that vulnerabilities concentrate. We know that children and young people from more deprived neighbourhoods are more likely to have adverse events. They looked at 5 adverse events in this case, which was self-reported physical and mental health, obesity, smoking, and academic achievement. And we know that children in the sort of highest 80 to 100%, or the lowest 20%, are like 10 or 12 times more likely to have experienced 4 or 5 of these adverse events. What we've also looked at is understanding inequalities in particularly the health system. At the minute, like I say, it started out with autism. So this is all looking around the autism diagnosis. And what was really interesting was SES as a composite measure wasn't really coming out. When you look at mother's education, that was what was really important. So a mother's education, if she was educated at A level, which is sort of the qualification just before university, it's optional, you don't have to do it. You finish mandatory education there. If you have that education or above, you're twice as likely to get a diagnosis, or your child was twice as likely to get a diagnosis, which is worrying. As you can see, massive sex and ethnic differences as well. And you can see why education becomes really important in the context of this, because the pathway to get a diagnosis for autism is not straightforward or linear in any way, shape, or form. This was some research done by a group looking at autism in the sort of dental context. And yeah, what you can see is pretty much the system that exists. It's not straightforward. Children get thrown into the system, and if the parents don't know how to navigate it, then it becomes really difficult. So what have we done because of that? So we know that we need to identify need early. We know that children that are sort of supported from a young age are going to do better. And what we've looked at is sort of routine education data. So can we use routine education data to start identifying children with need early? So one way we've looked at this is using the early years foundation stage profile. So that is the first formal education sort of assessment of children. It's when they're sort of 4 to 5 years old. It's not like a practical test, it's a teacher sort of questionnaire on whether those children are sort of have emerging skills, whether they're at expected skill level, or whether they're above skill level on a range of different measures, so like reading, writing, maths, but also things like language and communication, motor skill, pro-social behaviour, etc. And what we found is that it can help to identify risk of autism diagnosis. So I think children, when you look at the aspects of the early years foundation stage profile that map directly onto autistic characteristics, they were 50 times more likely to be diagnosed with autism if they'd scored badly on those aspects. And again, that's been replicated within the Connected Bradford data set recently. So children with autism are much likely to score much worse on the early years foundation stage profile. So that shows listening and attention, but it's sort of across the board with most of these sorts of skills that they look at. And beyond sort of just autism, we've done some research that looks at sort of whether this early years foundation stage profile can actually, predict whether a child needs special educational needs support at later life. As you can see on screen, it does it pretty well. So this was looking specifically at an aspect of the EYFSP called the good level of development, which is a binary yes/no measure as to whether they're expected or exceeding on the core skills needed for education. Again, there's been it's very government-led. We don't know how well this is defined, but yeah, you can see that sort of children that don't reach the good level of development are about 6 times more likely to need special educational needs support later in school. And again, this has been replicated in the Connected Bradford cohort as well. So you can see it's about 10 times more likely if you don't reach the good level of development that you're going to need some support later down the line. Do see ethnic differences as well, which is perhaps surprising, but I think we have a large cohort of mothers from South Asian origins that don't necessarily have the education qualifications, which we've seen that impact this as well. And again, males, but we see a lot of masculine and female autism as well. So really interesting. And what this has sort of led to is then, okay, we know that this measure is helpful. How can we take this like one step further? So this was a sort of trial where schools would screen using the EYFSP, but also something called the Strengths and Difficulties questionnaire. And children that scored below the good level of development and also struggled on the Strengths and Difficulties questionnaire would then be flagged for a multidisciplinary assessment. But what would happen is those children weren't taken out of the school environment for that assessment. Those teams would come into the school and do it. So rather than having to rely on a parent to take the child there, they're getting that straight away. And this is just some work that I've been doing this year on the Bradford data set. So looking at the underdiagnosis of developmental coordination disorder. So for those that don't know, developmental coordination disorder is a clinical motor skill diagnosis. So children are having significant and persistent difficulties with their motor skills that appear early in childhood. And what you're supposed to see is around 5 to 6% of children having difficulties and being diagnosed with DCD, which is around 2 to 3 children in every class, 2 to 5 children in every classroom. What we actually found was over the last 40 years, there's only been 154 diagnoses ever, which is wild. And we still don't really know why. We've had conversations with occupational therapists and physiotherapists who obviously are responsible for doing these assessments. What they're saying is they're getting way more kids through the door than that they think should be getting the diagnosis of DCD, but they're not the ones that can diagnose it. So that has to be referred back to a paediatrician. We don't quite know at the minute what's going wrong there. So yeah, really interesting. The other interesting thing we found with this is that no records at all of the movement assessment battery for children being used to, I guess, diagnose DCD. So that's the gold standard for diagnosing DCD in Europe. So if it's not being used to diagnose in clinical settings in the UK, is it used for construct? So what are we doing with all of this information? Well, we know that things aren't as great as they should be. We know that neurodiversity more broadly costs a lot of money, both in terms of health and education systems. And we know that the early years foundation stage profile and that sort of early educational context can give us some really useful information about those children that might need additional support later down the line. But the early years foundation stage profile was never actually designed to do this. It was designed to get school readiness indicator. It was never designed for sort of neurodiversity. So imagine what we could do if we had a tool that was purposely built from the ground up to help access services for children. So that's sort of what we're doing. we're trying to revise the system, which is, I guess, no small feat, but we want to make sure that everyone has an equal opportunity to access support for their needs, whether that be in a school setting or whether that be if they need more, I guess, comprehensive clinical support. So we know that we can't just put something in place, it has to come under a whole strategy, not just within schools, not just within health, but a whole district strategy. We really need to start getting parents to understand that what neurodiversity is, and it's not about getting a diagnosis of autism, and it's not about getting a diagnosis of ADHD, but it's about understanding your child's needs and putting relevant support in place. It will incorporate sort of whole school training as well, so people from, I guess, the lunch staff to playground supervisors to teachers, because we know that children encounter difficulties not just in the classroom, but for example, in the school hall, if there's like texture aversion. And then what we're planning to do is create an online electronic neurodiversity profiling tool, which will universally screen children for neurodiverse traits. And they all allow us to sort of put support plans in place at school level so that children can be first supported in that instance. If after a little bit of time those children aren't thriving still, that's when we can start bringing in those multidisciplinary teams to try and really figure out how we can better support them. So where did we start with this? Well, we started with the early years foundation stage profile, given it's quite useful for predicting these things. So on the screen, the ones in purple make up the good level of development. So these are the ones the government have said are crucial early learning goals. The ones in other colours are, I guess, less academically relevant ones, but are included. So things like understanding the world and people and communities. So if you get rid of those, what you have is the early learning goals from the EYFSP, or as Mark likes to call them, fundamental learning skills. And then what we've done is we've looked at those in collaboration with other academics and their expertise, but also looking at other neurodiversity tools which do exist, but are largely unvalidated and don't have much evidence for them. There's a couple that are used quite widely in the UK within educational psychology circles, but there is just absolutely no evidence behind them at all. So what we've done is created a longer list of these learning goals or fundamental learning skills. What we're hoping is that because it's electronic, we can collect a lot of this routine data quite quickly. Schools can upload class lists and all of their data onto this so that we can really look at gender and ethnicity, as well as English as an additional language, which is really important in our Bradford context. But what we're also hoping to do is be able to pull in other information. So schools have access to medical records, so they'll know, for example, if a child needs glasses, if they're really struggling to read in schools. Oh, it might be because they need glasses and they're not bringing their glasses in. But also pulling in other assessments that schools might do based on research, which I'll go into a little bit later. So we start off with a screener, and I guess the benefit of an electronic tool is that it's sort of changeable for every person. So teachers only have to answer questions that are relevant to that child. So a teacher will do a screener for every single child in their class. It consists of 12 questions which relate to those fundamental learning skills. And all they have to do is answer yes or no as to whether a child is performing similarly to other children in these areas. Got some examples on the screen there. And then this is the longer list of the screening questions. So the first two are sort of highlighted because we're not entirely sure at the minute whether we're going to include them as screening questions per se, or whether we can just pull in educational records to sort of shorten that list for teachers to do. Then what happens if a teacher highlights that a child has a specific difficulty in an area? It will sort of flag up a longer list of questions about that area, specifically looking at fundamental learning goals. So if a child had everyday movement difficulties, it would pull up questions around fine and gross motor skills. And then if a child, for example, had difficulties with their fine motor skills, what it pulls up is more specific questions. So here you can see these are the fine motor skill questions, so being able to manipulate tools, coordinating hands, using a single hand to achieve an object. And the scoring is pretty much in line with, I guess, EYFSP, because we know it works. But what we wanted to do was change it so that it's more sensitive at the bottom end of the scale. So rather than just having an emerging skill, we've now got lack skill, emerging skill, and then exceeded or expected, because we're not necessarily interested in the distinction between children doing well. We're more interested in that bottom end of the scale. So again, if that pulls up issues, they then go to further task competency, so very specific. Can this child handwrite in alignment with their peers? Can this child use scissors in alignment with their peers? And what this happens after this is they get a letter sent home to their parents, which outlines everything that the teacher has filled in, so that parents have a say in this as well. Because a lot of what we're getting from parent advocacy groups in Bradford is that, okay, well, schools see very different behaviours to what we see at home. And teachers don't always recognise that that's the case. So this gives parents a chance to sort of feed into the system and add in their experiences. And I guess the good thing about it being online is that everything can be refined. We're in the process of refining it currently. It's by no means done. So if anyone's interested in joining the fun with this, just let me know. We're going to be continually sort of updating this in alignment with teacher recommendations, but also we're going to be building this from the ground up with rationality, so it's got good structural validity. And what we're really excited about is that this allows research tools to be pulled in as well. So this is the sort of research that I did during my PhD, where I developed a universal screening tool for children's fundamental movement skills. Now, we know from the research that we've done that teachers don't necessarily know what good motor development looks like. So by giving them questions, it's not necessarily a useful thing to do, because we might not get those kids flagged. So what this allows us to do is get the school to screen their children, so they can screen a whole class in an hour compared to sort of an hour for a single child with clinical assessments, using resources they already have on schools. And we've developed it sort of iteratively across time, across sort of 3 years, on over 1,000 children in Bradford. And what we know is that teachers can score correctly. We know that they just aren't necessarily aware of what motor skill is and why it's important. It's not something that's included in the teacher curriculum, unfortunately, unless you're going for specialist physical education sort of qualifications. But what we also know is that the scoring of this and teachers' sort of scores of their children are aligning with clinical tools. So the movement ABC, which I mentioned earlier, Fun Moves sort of highlights. So we know that we're not sending children that are in need of support to the services that are already sort of overwhelmed. So what we're trying to do there is, again, flip the system. We've had a lot of feedback from occupational therapy and physiotherapy colleagues, which are saying they're getting a lot of referrals, but lots of them are inappropriate. So they always use the example of a parent coming in and saying, my child can't ride a bike. And they're like, well, do you have a bike? Has your child practiced riding a bike? Oh no. Well, maybe you should go and practice riding a bike before coming for an assessment. So they're getting a lot of that, sadly, and their services are overwhelmed. They had, I think, their waiting list was open for about 2 weeks, and they had to close it because they had 74 referrals in that time, and they only have one full-time member of staff. And that full-time member of staff isn't even a full-time member of staff to just do assessment. That's including things around cerebral palsy and more severe motor skill difficulties as well. So really overwhelmed. So what we're wanting to do, and what they're hoping that we can do, is sort of flip the system upside down and universally screen those children in schools, and then help them feed into sort of physical education curriculums to sort of better help schools understand how to develop these motor skills. If after a period of a term or a couple of terms these children are still struggling with their motor skills, that's when they will be referred to sort of specialist services that are more able to support those needs. But yeah, hopefully that takes out the, okay, well, your child just hasn't experienced it. We get a lot of that in Bradford. And then I guess another quite exciting thing that's happening at the minute is being led by Dr. Mai El-Shahaili. She is really, I guess, creating a front end for the Connected Bradford data set and really starting to look at, okay, well, the data can tell us a lot, but it can't tell us everything. So she's created the Clever framework, which is basically a visualization software, which allows you to look at sort of geographical differences, ethnic differences, SES differences, but what it also does is it allows you to overlay lived experience, so not just from parents on the waiting list, but the children themselves, and also things like policymakers. So we know that for policymakers, numbers don't mean too much, but when you can say, this is what the data is showing us, and this is what people in Bradford are experiencing, then it becomes way more powerful. So that's what Mai is starting to look at, but also sort of storytelling through visualizations as well, to make it sort of easier to understand, not just for policymakers, but also the general public. So the one on screen is sort of visualization of the autism pathway at the minute. It's a bit neater than the one I showed earlier, but it sort of shows where children enter and leave the system and where these difficulties might be. But it helps us map journeys. Like I say, she started on autism, but we're starting to look at that developmental coordination disorder pathway as well. So the vision, I guess, is to have a big, large data set that incorporates all of this data, so that we can better inform practice across sectors, not just in individual sectors, but also so that we can use research like the electronic neurodiversity profiling tool and Fun Moves to encourage bi-directional data sharing between health and education, so we can better start understanding the difficulties children are facing, but also better supporting them as well. I think that's me.
Have a lot of virtual applause as well.
Great. So any questions from online yet, or we can open it up for questions from people here?
Unmute type questions.
I'll go ahead and get started while we're waiting for any more questions. There was that interesting thing that you mentioned very briefly at the end about policymakers not being interested in data. Yet, like, you've obviously invested it heavily in data and see how effective it is. So you alluded to it a little bit about kind of how to translate, but just wanted to give you the chance to expand on that in terms of how you use data for what you do, and then how you kind of what part of that data or how you use that data then for talking with policy folks.
Yeah, it's a really, really tricky mix. And I think it's different for every policymaker you speak to and every group of policymakers you speak to as to what's really important. To give you an example, I went down to Parliament in November to discuss my research. And we had short sort of meetings with different members of Parliament. And what we quickly found was that what was really pertinent for some was not actually registered by many. So what we thought was important generally wasn't. It was more, okay, well, what are these experiences? What are the experiences that these people in Bradford are having? So that's where I think Mai's tool becomes really sort of important. We can show what the data is showing us and how differences are occurring, where they're occurring in the city, but also how that's looking in practice for families that are struggling.
Sorry, just clarifying that, I'm so interested in how, Bradford was able to do this, and just following up a little bit on that, what did you go in thinking was important?
Yeah,
I just to get a sense of the delta between how researchers think and how policymakers think.
Yeah, I mean, we thought what would resonate with people was largely, I guess, children that are having poorer educational achievement, poorer outcomes. What actually resonated with a lot of policymakers was, well, this is costing you a lot of money, not just in the healthcare service, but also in education. And when you get beyond that as well, so when you start looking at children that end up not in education, training, or employment. So yeah, it was really, I guess, higher order stuff that they were interested in. They weren't necessarily interested in what it means for little Jimmy in a school. They were more interested in what it meant for their service. Which I guess is it was a bit disheartening at the time, to be honest. But yeah, it's a very different way of trying to interact.
That's pretty consistent with policy.
Yeah.
There's a question here. It says, can this software be applied to any lines of service? I work in adult BMT-CT and am interested in identifying a software or program to help us manage donors and transplant and research. If so, who can I contact for more information?
Is that around the Clever tool?
Yeah.
Oh, sorry.
Yeah, no, sorry.
In terms of the Clever tool, it's still very much in early development. I suspect it will be able to be used outside of this when it's, I guess, ready to go. But at the minute, it's just being tested on one very small aspect of Connected Bradford. So, yeah, I can definitely put you in touch to share learning with Mai. But like I say, it's not fully there yet.
Another question, was the time of day for testing, this is from Ashley Sharma, was the time of day for testing a consideration for the testing or the environment? For example, if high masking females may pass when testing one-on-one early in the day or fail when testing a large group or later on in the day. Just curiosity around the parameters being proposed for future testing in schools and future states.
Yeah, no, really interesting question. And actually the EMPT has not been tested in schools yet. We're still going through the development process. So that's a really interesting point and one that hasn't actually been considered. So I'll take it back to the group in terms of when we need to start looking at this and when the time of the day does make a difference. Yeah.
I'll ask another question. I mean, when I was there in Bradford a while back, I remember you first starting to talk about the eyeglasses study, and just since then I've continued to hear, like in the US, like how much it comes up that like kids are just not able to read the board, really falling behind. And so that was a project I know you've been working on for a few years. Can you talk a little bit more about kind of where that project is at and kind of the successes you've seen there? Or?
Yeah, absolutely. So it's one of the really big successes of Born in Bradford, I would say. It's been being rolled out nationally now. We found really good sort of results that children caught up with their peers once they could
Wow.
see the board
Wow.
to learn the
Yeah.
material. So yeah, really, really powerful results. I think there was some issues with the analysis that was done by an outside provider as part of an RCT process, and they're not too happy with how it was done. So it's in the process of being redone by another provider, but initial sort of results were looking really, really promising in terms of children catching up on lost learning.
Cool.
Sorry, I know Sana's next, but it just made me think about that cost effectiveness. One can easily argue that the price of a pair of glasses is much cheaper than losing their earnings for the next 30 years.
I mean, we would hope so, yeah.
Sana Smith has a question. Sana, feel free to unmute it.
Hi, Dr. Eddy, and hi, all my PHS friends. I was really intrigued by one of the slides where you mentioned, I saw that this poster, which was nothing about us without us, and I'm really interested in sort of the participatory research component of One in Bradford, and I was wondering if you could elaborate a bit about how collaborating with the people in Bradford have influence data collection or data analysis or data interpretation.
Yeah, absolutely. So co-production is a core part of what One in Bradford do. So I can give a couple of more specific examples around what's been done. So the big one at the minute is the Age of Wonder study, which is where we're tracking the lives of the BIP cohort sort of through secondary school. There was a large sort of year-long co-production phase with secondary school children before it started to understand what is really important for them. They've been involved in sort of setting the priorities, so starting off with sort of mental health, but they're also continually involved. So I think there's a group of about 60 pupils that are going to be involved throughout this 5-year sort of secondary school span. So they meet sort of every couple of months to sort of review what's being done and give their opinions on it. So that's one example. The other really good example of this is a study called Act Early, which is done in collaboration with London, looking at sort of really deprived neighbourhoods in Bradford. So I think the 3 most deprived neighbourhoods in Bradford, where there's been a lot of interesting conversations happening with the sort of community. So in Homewood specifically, which is the poorest neighbourhood in Bradford, what we were finding is the priorities of researchers really actually contrasted with what the community wanted. So researchers went in thinking, oh great, we've got this neurodiversity profiling tool, surely that's going to be helpful to you people. And they came back and said, actually what's really important to us is that we're safe and secure. What they're finding in their sort of region of Bradford is they're not getting public service buses to that area because children are skipping school and throwing bricks at them. So what they're really interested in is trying to get children out of that sort of criminalised behaviour so that people can get to work on public transport, don't have to use the fast food sort of in the local area, and can actually get to the supermarket. So it's been a journey, definitely, and one that BIB are continually trying to go on, particularly given the demographics of Bradford. We know that us sitting here in our university institutions is not going to be all that helpful to people. So one way BIB really try to do it and do it really well is hiring in locals to do sort of co-production work and working people that already know the communities. So for example, in Homewood, they had the community action group, which sort of led on that sort of co-production work and researchers fed into it. Really trying to build trust through pre-existing, I guess, organisations and communities. Does that answer your question?
Yes, thank you so much. Are there any white papers that have resulted from these collaborations that are good to share?
Yeah, I can send you some.
Okay, fantastic. Thank you so much.
The next question in the chat, and something Lucy and I talked about just before this, is how would a researcher get access to the data? What are the requirements, and can a researcher from outside the UK get access? And the short answer is for Born in Bradford, yes. And in fact, we have it on sort of a separate portal, very similar to the PHS data portal. The original plan had been to repatriate the data back to Bradford probably this year, but the pandemic has delayed that. They're in the process of developing their own platform. So the plan is to move the data from this other portal back to the PHS data portal, so it's all integrated, easy, convenient to get access to. And then the steps are pretty straightforward. It's about like getting access to, say, MarketScan. So I think you have to take PD, probably HIPAA, but it's not that bad. If you're using any other PHS data set, it'll probably take you a week of back and forth. It's not bad at all.
I guess it's worth mentioning the need for an expression of interest. Well.
Yeah. That sorry, that was the week back and forth. So there is a short 2-page application that you do have to fill out and send to Bradford. It's very similar to several of our other restricted access data sets where you do need the approval of the data owner. And then you just attach that approval in the portal. Bradford is always helpful and thoughtful. So like if in the cases I've seen them say no, it's almost always because they're trying to help steer the research in a more feasible direction, or just trying to help, get them to collaborate or whatever. So it's not onerous at all, and very high probability of success because they help to make sure you succeed.
I have a question that's a hybrid of those last two questions, which is something I've kind of struggled with a bit when thinking about projects with the Bradford data. Is from here in the west coast of the U.S., we're not involved. We don't know at all what's going on in those communities or what kind of questions would be most useful. So if we have a research area but really want to do something that's responding to the needs of people in Bradford, how would you suggest we kind of go about that?
Yeah, and I think this is how probably some of the most, impactful work happens within BIV. It's researchers that come from outside and say, this is an area we're really interested in, and what we can do is then put you in touch with people on the ground that are sort of seeing how that's impacting real lives, and you can sort of work together to put together research questions. So what BIV is really keen on is collaboration, right? And they're really keen on this collaboration with Stanford. So there are lots of researchers at BIV that would be more than happy to join forces and sort of help you along that journey.
All right, well, if no other questions, I'd just like to thank you again. Fantastic presentation, and excited to start working with you more on the data.
Thank you, everyone.